Hello and welcome back to acing AKT. Abim here, and I just wanted to start by saying thank you to everyone who has subscribed, liked, and shared this page. If you haven't yet, please like, subscribe, and share with your friends. Today I'll be doing a clinical series on neonatology, which is a very exciting area of medicine for me. I think this series would be useful for people who are doing a pediatric rotation as a GP trainee, or perhaps as an F2. It would also be useful for people who are doing a GP job as well, because you get to see children and adults and everyone in general practice. So why not start off with the little ones? I will be doing a sort of neonatology masterclass, and this is the first of the series. I will try to make it as sort of patient-oriented and sort of tell a story as I go along, and I hope you'll enjoy the series. I apologize for the boring slides, but yeah, bear with me, please. And I hope you enjoy and learn one or two things of this, okay? So right, let's dive in. So we will be starting off with baby Smith, who is a 38-weeker who is the second baby for his mom, and he is being born by elective cesarean section as he's remained breech. So this is his second day of life, and you've been called up to the ward to have his NIPE done. And you're like, what is NIPE? Because that's how I was on my first day of pediatrics. I'm like, what is NIPE? So the NIPE is one of the screens babies get. Is one of the screening programs in the UK and the full meaning of the NIPE is the newborn and infant physical examination. And what it is a top to toe exam, which all babies have. You have to ask the mom for consent to sort of do this examination for the baby. And the essence of the examination is sort of pick up congenital abnormalities. And the earlier we get to pick them up, the earlier we can do something about it, and the earlier, we can improve the overall quality of the life of the child. And that's the essence of the screen. So ideally, you need to get the screen done within the first 72 hours of life. And many times, babies would not be discharged except they have the NIPE done. So you would have midwives hounding you if you were doing the neonatal job to say that, oh, this baby hasn't had his NIPE done and they need to go home like yesterday. So please, can you get it done? So yeah, you'll be getting a lot of that from the midwives. And the follow-up from the neonatal exam is the 6 to 8 week check, which usually happens with the GP, and that's where the GP trainees who are doing general practice would get involved with sort of the NIPE. And I think the essence of having the follow-on with the GP is just in case things were missed in hospital, then the GP can sort of address that, because, sometimes things could get missed. The NIPE looks for some main conditions, although it's a top to toe exam, looking for other sort of abnormalities or maybe deviations from norm. The main conditions we're looking for when we do the NIPE is the eyes. So we're looking at the eyes, looking for presence of the red reflex or absence of the red reflex, which signifies congenital cataracts. We're looking at the heart, looking for murmurs and also feeling the femoral pulses, because congenital heart diseases, and you could get coarctation of the aorta, which you could find with absence of the femoral pulses. Also, you're looking at the hips, because you need to look for developmental dysplasia of the hips. So you're doing the Ortolani's and the Barlow's maneuver just to try and dislocate and relocate the hips in case they're dislocatable. And then in boys, you're looking at the testes. You're looking for bilaterally descended testicles. So if they haven't got bilaterally descended testicles, then you might want to flag that up as well. So some people are at higher risk of having this problem. So if you do have a parent or a sibling, so a first degree relative, so that's parents or siblings who have had either heart, high, hip or testicular problems, you still have a higher index of suspicion. So even if the baby presents well, even if they haven't got any clinical signs of the pathology, you're still going to refer that on for them to be further screened. In terms of the hips, so we have a number of risk factors, and I think the hip is the biggest of all of them all. So you need, if the baby was born breech at over 36 weeks, or if they were breech at over 36 weeks, regardless of their delivery, if they had external cephalic version, you're going to also still refer that baby. If you have multiple pregnancies, so for instance, you had twins and one of them was breech at 36 weeks, regardless of the method of delivery and regardless of the other twin being cephalic, you're still going to refer both babies. So if you have multiple pregnancies, every baby in that pregnancy, so if you had triplets and one of them was breech, all three of them have to have an ultrasound. If you have twins and one of them was breech, both of them have to have an ultrasound done to look for developmental dysplasia. If you have any breech delivery after 28 weeks, so if you had a preemie who was born at 30 weeks and they were breech, they have to be referred for an ultrasound. And if you do have risk factors, so if a parent or a sibling had hip problems and then they had a brace or they had an operation, then you need to refer that baby. So if you found any of these risk factors, then they need to be referred at 6 weeks, regardless of a normal clinical exam. So if you examine them and they had nothing, then you would refer them at 6 weeks. Yeah. So if you did find a dislocatable hip on exam, then you need to refer that for an ultrasound at 2 weeks. So let's go back to baby Smith, who you did his NIPE and he looks brilliant. He did not have any sort of dislocation on his exam. So we would refer that for an ultrasound at 6 weeks. But if, on the other hand, baby Smith then went on to have a dislocatable hip, then we would be referring that for an urgent ultrasound within the first 2 weeks of his life. And if he did have a dislocatable hip, it's worth mentioning to mom so that she's aware that if she goes on to have another pregnancy, even if the baby was cephalic, even if the baby was well and had nothing, he would then also have a screening ultrasound at 6 weeks because he's at risk of having hip dysplasia. I hope that is a bit clear if you did not have a clue previously. So if you did find any sort of absent red reflex, you would be referring that to be seen ideally by the 2nd week of life. So you'll be referring to ophthalmology, who would ideally see the baby within 2 weeks of life. If you did find bilaterally undescended testes, then you need to get a pediatrician's review. So you'll be probably escalating that to your registrar if you're in hospital, or to your consultant if you're in hospital, because that needs further investigations to rule out metabolic and possible intersex conditions. If you did find a unilaterally undescended testicle, you need to get the GP to review that in 6 to 8 weeks. So maybe if you're doing the discharge letter, you put on the discharge letter for GP to review. You mentioned that they had an undescended testicle. You would also write this up in the red book. So if you're in GP and you're seeing the baby at 6 to 8 weeks, then you want to be reviewing what is in the red book, where the NIPE was done, if they found any abnormalities, and if they needed you to action any any sort of suspected abnormalities. So if you're reviewing that in 6 to 8 weeks and they still have an unilaterally descended testicle, then you would want to review that again in a couple of months just to be sure that it's fully descended. Otherwise, you'll want to refer that on to urology or to the surgeons, whichever your pathway is. And if you did find a murmur or you found some absent femoral pulses, then you want to be getting an urgent review on the same day, perhaps with your registrar or your consultant if you're in hospital, or if you're in general practice, you want to be ringing up the pediatricians to say, oh, I'm very concerned about this child and they've got a murmur or they've got XYZ, so the pediatricians can give you a plan, which hopefully would be send them in and we'll see them. So the next thing I will be touching on is the 6 to 8 week check. But essentially, you're doing a top to toe exam, similar to the NIPE, if you've ever done a NIPE. But if you've not, there's sort of great resources on YouTube that you could watch, and hopefully that would help your knowledge. Otherwise, you can mention that to your practice that you've never done one, and you can observe a few being done, and then you can sort of do one yourself. But essentially, you're just doing the same thing as what we've discussed in the NIPE. So checking the eyes, the heart, the hips, and the testicles if they're boys. And you're also sort of doing a top-to-toe exam, checking their backs, checking their anuses, making sure things are patent. You're looking at the penises as well if they're boys, obviously. And you're looking at the orifices to make sure they haven't got any sort of hypospadias or things like that, because those things can impact baby's life going further down the line. And then you're also checking if the parents have got any concerns with feeds, any concerns with growth and things like that. And it's worth mentioning here that before the babies have their 6 to 8 week check, they would usually have like a weigh-in with the midwife or the health visitor, so yeah, they would usually have that done before they come to see you. So that's really handy, just to check that they're not losing weight and things like that. The next thing I'll be talking about is the newborn blood spot. So on day 5, babies would usually get a visit from the midwife just to check that things are all right, they're settling in well, and the mums and dads have got no concerns, and babies have sort of regained their birth weight, because in the first few days of life they would lose weight, and then you're expecting by the 5th to 7 days they're sort of gaining their birth weight again. So on this visit as well, they would usually have some blood tests done, which is the newborn blood spot, where you're looking for, it's another sort of screening test as well, where we're looking for congenital errors of metabolism and some congenital problems actually. So they screen for all of the conditions are very rare. They're all autosomal recessive. So they're screening for congenital hypothyroidism. They're screening for sickle cell disease and cystic fibrosis as well. And also they're screening for lots of other inborn errors of metabolism. All these amino acid weird and wonderful things. So that's what babies would get. So they get a blood test on that day as well. So baby Smith had gone home after he did his NIPE. Thank you very much. And when the midwife got to him today, she then noticed that, baby Smith looks a bit yellow, and she wasn't very sure. He's feeding well, he's regained his birth weight, and she did a TBR on him, which is a transcutaneous bilirubin, and that came back to be a bit high. So she was a bit concerned and spoke to the pediatric unit and sent him up to have a serum bilirubin. So we'll be talking about jaundice, which is very exciting. But yeah, jaundice is sort of yellowing of the skin because of high levels of bilirubin, and then it sort of deposits on your skin, and that's because of degradation of red blood cells. And we know that babies have got loads of red cells because there's a bit of hypoxia and things like that when they're in utero. So they sort of compensate for that by having increased red cells to help circulate the oxygen and things like that. But yeah, it's very common in newborns, and essentially when you see a baby particularly in the first few days of life, you need to sort of examine them under bright lights, because you can then appreciate whether or not they've got jaundice. If you notice that they've got a bit of jaundice, then you need to sort of examine them, have a look at their scalp. Sometimes you might get a bit of cephal hematoma from where they've had like instrumental deliveries, and then it's just sort of blood pooling there, and that is another excuse for them to have jaundice, essentially. You're also checking if they've got a temperature, because they might be septic and that's causing them to be jaundiced. You're checking that they're gaining weight properly, because they could have other conditions, and if they're not feeding well, that puts them a bit more at risk of having jaundice. It's worth also checking blood group with mom and rhesus group also of mom, but this would usually be checked in the hospital when the baby goes in. So if you're doing a hospital rotation, you would want to check the serum bilirubin. You might want to check the blood group and rhesus group, and then do a DAT test. So those are the things that you might want to do maybe before your registrar comes, or you might just put that in your plan so that they know that you're an ACE GPST. So you assess the feeding, whether or not they're bottle or breastfeeding. If they're bottle feeding, then you can work out the volume of what they're having. So around the feed, you'll be expecting that they're having about 150 mils per kilogram of feeds. So sort of just work that out with mom and see how much she's feeding. She might be under or overfeeding baby, and that is contributing to jaundice as well. Check that they're passing wee and what color their wee is, and also check whether or not they're making stools and what color their stools are, because you would like to rule out biliary atresia as well. If you do find a baby who's got jaundice and you're maybe doing an exam in general practice for whatever reason, then you want to be ringing up that baby and sending them to the hospital. If they've got signs of being limp and poor tone and things like that, then you're calling for an emergency admission, sort of same day admission as soon as possible, so that if at all they could maybe consider starting exchange transfusion in hospital if the baby's got kernicterus, then perhaps they would need exchange transfusion. If the baby is less than 24 hours, then you want to be getting a same day review, because that's not normal. So you don't get physiologic jaundice less than 24 hours. So if baby Smith was a home delivery and you had to go see mom for whatever reason, and she's like, oh, look at my cute baby, and you're like cuddling the baby, and you find that, oh, he's yellow, then you unfortunately have to send that to hospital on that same day. And this is sort of areas that I think are tested properly during the AKT. So I found quite a few questions when I was revising for my AKTs, things like baby is limp with poor tone and things like that, what do you do? Then that would be an urgent sort of assessment in hospital. Things like if the baby is less than 24 hours and you notice that they're jaundiced, then that also warrants a same day assessment. So there are other conditions where you get like prolonged jaundice, and that needs also to have an urgent assessment, because it could be the onset of sort of biliary atresia, and that needs to be seen urgently. I hope you have managed to watch almost 20 minutes of this lecture. I've decided to sort of do just these topics because I found that if I was going to record the entirety of the slide of my presentation, then I would have run you into an hour or something, and I thought that would be too long for you to watch. If you really enjoyed this, please by all means like, share and comment, and just so that I can know if it is content that is useful to you. So that'll be all for now. Until next time in the clinical series, do take care, and I hope you did learn something today. Bye.